So I just want to say that, that research and clinical trials are really important because I think as clinicians we don't want to keep having people come in and you say, well, you know, we really don't have a lot new to offer, and that's not going to change. You know, what's the old definition of stupidity is doing the same thing over and over again and expecting a different result. So, so to the point about the community, the need to go out to the community, we for many years have been working particularly within the retirement communities around Portland, and they've been tremendously supportive. And the people who live in these communities are often, you know, they will often say, well, nobody thinks I'm able to do anything anymore half the time, and they're very willing. So that point about going into the community is extremely important and well taken. So we're going to switch gears a little bit here and talk about assessment and diagnosis of dementia. And I know that this group is of varied backgrounds, and so I think at some points I'll be saying things that are elementary to some and maybe not so elementary to others. So bear with me if things are at the wrong level, but hopefully in the end it'll all even out. So with that in mind, there's really two very simple goals of what I want to discuss today. One is to talk about essentially the assessment of dementia, and then armed with the tools to be able to assess dementia, how that fits into actually making a diagnosis. So this is a very simple question. Why assess cognition? You might say, well, gee, duh. However, it's surprising, you know, 50% of people with dementia, not just memory concerns, go undiagnosed. So there's this pervasive thought that clinicians kind of don't think it's worth assessing. So these are some of the reasons that despite the fact that there are no new treatments, there are many treatments. And when I say treatments, everything isn't a drug. There are many important other things that need to be done. And the proper procedures are really based on ultimately knowing what you're dealing with in a diagnosis. There's a lot of concern about dementia and having cognitive problems, so the idea of demystifying and destigmatizing concerns about cognition. This blends into also talking to family and friends about what is changing or not. It provides the opportunity to get access to information and resources and to plan for the future. And then ultimately all of those good things will hopefully lead to maximizing the quality of life. And then finally, for those who feel that these are just too soft, the bottom line is also there's even evidence that, that diagnosing cognitive impairment is actually associated with decreasing healthcare costs. Is anybody here from Washington? Okay, you know what to do when you go back. Washington State, you probably meant. No, I meant DC. Okay, so now that you're totally convinced that we really should be assessing cognition, how does this all work? Who comes in? How does it come together? And the first part is actually knowing what people are thinking about their thinking. And it really depends on how you ask the question. So there have been a lot of studies over many years in different aging populations, and probably the one that had the most comprehensive assessment of cognition. So it didn't simply just ask how's your memory, but used a large number of standardized and semi-standardized questions, up to 24 questions, that dealt with things that had to do with problem solving, reasoning, memory, and so forth. And if you ask all of those different possibilities, well, just about everybody over the age of 65, essentially, had at least one subjective cognitive complaint. In the Sydney study that I'm referring to, about 65% of the individual themselves felt there was a memory problem, but only 35 of their so-called informant thought there was a memory problem. Interestingly, on a question about problem solving and reasoning, there was much less, and there was much more congruence between the two. However, to the point of it depends on how you ask, there was a question on a separate questionnaire in the same study. The questionnaire comes from the IQ code, and it was asking if there was a problem with learning how to use a new gadget. In that case, 26% said that the person they knew well was having a problem. So how is that different than problem solving and reasoning? It really does depend on how you ask the question. Nevertheless, uniformly, memory complaints are common. They come up between 34 and 65% of these kinds of studies. They're typically, these are the kinds of questions that are asked. And these positive responses do have implications. So, just on a statistical population basis, you are much more likely to develop dementia if you have some subjective memory complaint. However, it's very hard to predict in an individual sitting in an office setting or clinic exactly who that person will be. But we'll get into a little bit about how you might go out making or understanding how the subjective complaint is important. I also want to point out that there are many other studies, and I don't have time to go into this, that show that people who complain or feel they have problems with their memory also have problems with their mood and depression. And then finally, always keep in mind that people with frank dementia, people who, there's no question this person has impaired cognition, have impaired insight into their memory, and they will actually respond to similar questions that they don't have a problem with their memory. So the subjective world is subjective. What about objective approaches? Well, what we think is the objective approach is to do formal tests of memory. Now, these are not normally done in real life. I don't know how many of you sit around memorizing lists of words or things like that, but that's how this is done. This is a graph from one of the most famous longitudinal aging studies, the Seattle longitudinal aging study that's been going on for over 35 years. And it just shows the different colored lines represent different cognitive domains that were tested. And so this is numerical ability. See if I can get these colors right. There used to be a scale on here. I'm not sure what happened to it. And I think the blue is memory. This is reasoning, a reasoning function. The point is that over time, there are clearly almost uniform declines, but they aren't all in the same magnitude. These are all normalized so that they're all equally scaled. The other thing to keep in mind is, despite the fact that there is clear changes, the changes are slow. So this is a separate study that was published a few years ago by Tim Salthouse, a large number of younger adults from the 20s out to I think 55 in this study. And what you see is uniformly. So this is several memory tests. This is a test of reasoning, spatial domain, and speed and cognition. And so the actual changes are relatively small, certainly year to year, but they're definitely clear. And then the envelope is somewhat different. So for example, speed is the thing that has always the steepest decline. Actually, when you're very young, you're really pretty good. And then, as we know, that you kind of slow down with aging, even if you're 55. So, but the good news is, in some ways, that this decline, this decline is what we call normal aging, is different than the decline that we now know is associated with developing more pernicious change, that is, developing more, leading to dementia. And there's this period called mild cognitive impairment, which I'll talk about shortly more formally, that precedes dementia. So this is data from our Oregon Brain Aging study, a community study, where we go out into the community. And it just shows in several domains. So this is a test where people are asked to recall a memory, information from a paragraph, a story. And here's an immediate recall, and this is a delayed recall. And what you see here is the normal individuals, actually look at this. After years, this is over a decade of testing, they're actually, what are they doing? They're getting better. So people do learn. In fact, it's a problem with some ways that you do cognitive testing, but that's normal. These individuals actually didn't, in retrospect, learn. And then right before this dotted line, they had this very steep decline. And these individuals eventually almost all go on to become demented. In the visual spatial realm, it's actually different. So there actually are, the declines are very similar, but again, there's this kind of rapid fall off, for example, when you get to a couple of years before dementia. I should mention, relative to what Dr. Quinn was talking about, this opportunity to perhaps treat people early. The fact that we can detect these changes before the mild cognitive impairment sets in is rather promising to many of us, suggesting that we might be able to do something really early. So just to summarize 50 years of several thousand people doing research on one slide. In general, cognitive complaints are absolutely common. They're normal with aging. They begin early for normal aging. They increase slowly in normals, but with pathology, they decline more precipitously. The domains that are especially sensitive are any kind of cognition that requires speed and complex multitasking, so-called executive tasks, and of course memory, as I mentioned. These, as I mentioned, the year-to-year change is small and can add up over time. And this is something that I always like to point out, that if you took an 89-year-old person and who was not demented but had that slow decline that we showed over time, and then you plot it out if you were 20 years old, where you'd be on that graph. On average, you'd only have to be about 50% as good you would be 20. If you were 20 years old, you would have already had a 50% drop, which on a delayed memory recall task, for example, which probably would mean you'd have difficulty actually taking most standardized tests. So just to think. These tests have a lot of variability, test-to-test variability in particular. So the bottom line here, and the summary, is that the things to keep in mind are the frequency, the time, and the type of testing can be very large as even the aging effects. So whenever and we're going to talk more about testing, whenever you're testing somebody one time, you always have to keep that in the back of your mind. And then secondly, the timing of the testing in terms of when the person is being tested, as well as on that curve, as well as how you test them makes a big difference. So how do we test them? Well, how do we know that there's a change? So the overlying principles are that we try to define those thresholds for when somebody is crossing a line or a trajectory that is indicative of being destined to develop dementia, essentially. And those individuals who cross that line, we currently refer to as MCI, or mild cognitive impairment. And this is something that, actually, the concept's been around for a long time in different forms. Probably the oldest term was benign senescent forgetfulness, which was, I think, coined in 1962. But there have been other terms, related terms: age-associated memory impairment, cognitive impairment, no dementia, or SIND. And these are all cousins, but the most commonly and I think widely used term is MCI now. MCI is most commonly defined, and this comes out of some consensus conferences and things like that, that more and more have been over time more recently formalized. So there's initially a concern regarding a change in cognition, so that there is a subjective complaint, realizing how variable that may be. There's an impairment in one or more cognitive domains. Usually it's memory, particularly if it's a person who's going to develop Alzheimer's disease. Those individuals are sometimes called amnestic MCI. Despite these cognitive impairments, there's preservation, and I put in parentheses relative, of independence in functional abilities. So sometimes people are, on the surface they look fine, but actually if you scratch the surface, there may be some difficulties. All this, it's not like taking a pregnancy test where it goes from pink to blue, or I don't actually know the colors, but there's a transition across these states. By definition, they're not demented, which means they don't have functional impairment. And to keep in perspective, this syndrome, this collection of difficulties, if you have that syndrome, you are at risk to develop dementia by about 10% a year. So it's not benign. So how do we operationalize this cause for concern and differentiate normal cognitive aging from MCI or frank dementia? And the three key issues are, is there objective evidence of cognitive impairment, so beyond the subjective complaint? And what is the status of function? Does a change in cognition affect how the person performs in their usual activities? Does it cause so-called ADL, or functional impairment, activities of daily living, or functional impairment? And then the other factor, which I think is sometimes missed, or is just something that's difficult for us to deal with because we may be seeing somebody for the first time, is the pace of change. And this may become more apparent as you follow somebody, but if you've only seen somebody for the first time, you're really relying on the person or their family, usually, to give you a sense of that change. And so it's these last two features in particular that really define dementia. That is, that there's a progression of decline that's significant, and that progression of cognitive dysfunction has led to activity dysfunction. More formally, what I just said is codified in this list of criteria. Again, there's been a revision of these criteria a couple of years ago now, but they haven't really changed that much from the original ones from 2004. And they actually, I'm actually not going to go into this in great detail because I just encapsulate it, but the key is that there's a decline from previous levels of function that interferes with usual activities. This is not due to a obvious medical illness, a delirium, a psychiatric problem. The cognition is not simply in one domain, so it's memory plus at least something else, or it could be two of other things with relatively minor memory problems, but there's multiple cognitive domains need to be involved. I just mentioned that dementia is not delirium or acute confusional state, and this gets back to the pace of change that I was talking about. So delirium usually occurs in the setting of an underlying illness or acute illness that might be present for days or weeks. There's usually a more rapid pace of onset. There may be some fluctuations. Persons are often disoriented. As part of that, they characteristically will have disturbed sleep-wake cycles. And usually, or hopefully, these are reversible, but keep in mind they may be superimposed in a person who has dementia. And the common scenario in hospital settings, or not common, it's not Not every patient enters the hospital develops a delirium. But not uncommonly, patients will have a dementia and it's not recognized, because if 40% of patients with frank dementia say, I don't have any problem, and you walk into the room and you say, ready for your surgery? It's, oh yeah, sign here, yeah, okay. Hopefully it's not quite that bad. It's not that bad. But I'm just exaggerating to make a point. But it is not uncommon that there'll be under-recognized cognitive impairment, and then under the stress and other complications that are potentially available when you have a surgical procedure, it ends up being like Gilligan's Island. It's not a 3-hour tour. It's a long time recovering with a delirium, which was superimposed on dementia. The other issue that I mentioned is that dementia is not depression. Depressed mood certainly does coincide with memory loss. The characteristic responses of a person who has a significant mood disturbance is a lot of passive answers, a lot of I don't know, I can't, I really don't want to do this, I can't do this. They will have short and long-term memory loss, although that really isn't that distinctively different in some ways. And the functional decline, again, may be greater than their actual cognitive deficit. So the person is actually able to do things they need to do, but they seem to test much more poorly. And they're often anxious. So how do we evaluate dementia? Well, this is the theme that I emphasize, to just have the perspective of, you do what you can, you have to do what you can, but I think it's more of a process. A single visit is a very blunt instrument, or not a very blunt, a very insensitive instrument for assessing or diagnosing dementia. And that's for a number of reasons. We're really relying on the recall or self-report of events. The tests that we use are artificial, they're not fun, they make people uncomfortable, not infrequently. We always test people at times that are convenient to us. So I don't actually know much about dementia during nights or weekends. There's a lot of inter-rater, that's different people's ways of administering tests. Actually is not always the same and causes a lot of variability. And then when we see a person, it really is just a snapshot of their function, which may not represent a typical daily visit or daily activity. And then finally, and probably, one of the things that's probably the most challenging in many ways is trying to integrate all the other things that could affect how this person is when we don't really know them very well at that time. So we don't know much about how they really sleep, their socialization patterns, their medication adherence, their physical activity. These all have tremendous potential effects on history taking and cognitive testing. So those are the challenges. Well, but how can we overcome them? So the best way to overcome them is actually to have more than one opportunity to talk to people and get more information. But in general, what we do rely on is, to that point, is history from others in addition to the patient. So clinical history from the family or friends is essential. The symptoms are very typical. So people with particular memory problems will often very commonly talk about repeating themselves, or they may not repeat themselves, their families will talk about that quite a bit. Losing common objects around the house, having difficulty with orientation. So it's not, if you ask most people, for example, do you have trouble driving? Well, they typically will say no. Or if you say, do you get lost? They'll say no. But if you ask, do you sometimes feel like you're not certain where you're going or a little turned around? That will commonly be responded to with a, oh yeah. Eye contact, I don't have this on slide, but eye contact is one of your most powerful tools, because neurologically when people are lying, or not lying, but uncertain of their answers, you can actually watch their eye movements, and you get a lot of information from that. The course is something that I keep emphasizing this afternoon. I was almost going to say this morning. So trying to get an idea of when things started and how it progressed is very helpful. Typically, people will tag the onset with an event because it's human nature to do that, but it's often, in retrospect, clear that it didn't start right after they, had an auto accident or a dental procedure or something like that. We ask a lot about people's mood because that clearly affects cognitive function. And finally, issues with regard to physical function are very important. So we look for changes in walking, movement, tremors, and things like that. And I mentioned incontinence on this list here. The other part of the history is to look for risk factors because this adds to your certainty or uncertainty, depending on what you uncover about the type of dementia. So age is the most important risk, but we all know that. Family history of dementia does increase your risk, certainly with a first-degree relative. Most genetic factors are rare in terms of mutation. Apolipoprotein E4 is a risk factor associated with Alzheimer's disease that increases your risk, like depending on the study and the group you belong to, from 3 to 15-fold. If you have Down syndrome, you're at increased risk. The history of depression itself increases your risk, along with the baseline risk of depression. And then head injury, mostly this is related to repeated head injury. I think the NFL story has become a big thing in the news. The repeated head injury, also in the VA system. That's another big problem of returning veterans with multiple blast injuries and concussive injuries. So that's a risk factor for dementia. And finally, it was mentioned in the last talk how important vascular disease is. And so the last item, vascular disease, and the first item go hand in hand. And most recently, it's been shown that people who are in their 80s have hundreds of microvascular lesions normally, and we haven't been able to see them until recently without a special scan that was devised. The symptoms, I actually kind of went over some of these, but people will describe, these are early changes, difficulty managing finances, so somebody took over paying the bills, difficulty with driving, getting lost, not as common as just turned around, maybe a little trouble using a cell phone in particular, not a landline. The person doesn't give as much information as well as they used to. They forget medications, or somebody's having to take that over for them. There's less attention to personal care and hygiene. Missed appointments can be a sign. And then in general, there are some personality behavior changes for some dementias where the person may be more passive or seem to be even suspicious or even paranoid. The exam, so sort of going to the physical side of things, there's three components I would emphasize today briefly. One is the mental status exam, the second is the depression screen, and then finally just a few comments I'll make about the physical exam and neurologic exam. So in the primary care setting, there's limited time. The average follow-up visit in primary care is between 15 and 16 minutes in the US, which is actually the average time in the waiting room is, I think, 26 minutes in the US. But so in most of these, most screening tests are about 10 minutes. So the math doesn't add up very well. In any event, we press on. So really what that means is one does have to efficiently try to go to some kind of more screening evaluation, at least, to set up how you're going to spend your time in the future to really figure out what's going on. The mini mental state exam, has anybody ever heard of that? So probably 10 years from now, no one will hear about it This has been the most widely used test. There's been a whole story about copyright infringement because it became copyrighted. So it's rapidly falling out of use for that reason. And two other tests, I believe, have really kind of supplanted that for a number of reasons, which I don't have time to go into today. One is called the St. Louis University Medical Status Exam, or the SLUMS. I don't know why they decided SLUMS was such a great idea. And the other one was much better. I think Starbucks had something to do with this. The Montreal Cognitive Assessment, or the MOCA. I'll have two of those. So just to briefly, how many people here are familiar with the MOCA? So this test has, in a person who's doing well, it takes about 10 minutes. It has 8 domains, so I can't show the whole form on one slide, but this is the top 3, and then I'll just show the bottom 5. And again, I'm not going to go through this in great detail, but so there's a visual, spatial, and executive function test. These are mixed tests. This is a trails test where the person actually originally does the first bit, and then so 1A, 2B. I realize I can't do this standing up. 3C, and so forth. And the idea is to connect the dots. And then this is to copy a cube, draw a clock. I'll talk about that in a moment. Name these very common animals. And then there's this memory test, 5 items, where you actually just ask the person, you tell the person the words, and then they're going to remember them. You don't actually score the immediate number they recall, which is interesting, but that's the way it's done. And then as the test moves on, there's a digit span where you ask the person to read a list of, you read to them a list of digits, and then they're supposed to give them back to you. And then another test of attention where you give them a string of letters. You say this out loud, and every time there's an A, they are supposed to tap with their hand. And then the famous serial subtractions from 100 here. There's a language test, category fluency. So many people consider this to be an executive function task. Tasks of similarities for some reasoning. And then you come back and you ask the person, do you remember those words? And that's what you see here. And the score is really only with no cues. This is optional for your own information. And then at the end, actually, is orientation. So it's interesting, the mini mental state exam, the orientation's in the beginning. They couldn't help themselves. They had to put it in. So there it is. And the scoring it's interesting. The SLUMS and the MOCA both have this 30-point, so that's nice and familiar to those who got used to the mini mental. So this is just some of the original data. There's a website, mocatest.org, that has excruciating details. It's actually been translated, I think, over 20 languages. So they've done a nice job of trying to keep this available, but they do ask that you ask them for permission to use it. The cutoffs are here on the bottom. So it's 26, and then these are actually the same because to get demented, you have to have a functional impairment, so it's not just totally based on the cognitive score. There's also an education adjustment as well. And I'm not going to talk a lot about the SLUMS, but many of the items are somewhat similar. I just pulled this, this is just a screenshot. There's an iPad version now. It costs $1.99, that's not free. But it's kind of interesting, and I'm not going to go through it all, but it has the same, many of the same components, but done in a different way, and some different wrinkles. I don't own stock in either one. I think the most important thing is to pick one and get comfortable with it and use it consistently. There probably is a bit of a nod toward the MOCA. I can tell you that the National Alzheimer's Coordinating Centers that the NIA supports is going to switch. Is switching to the MOCA. Oh my gosh! No, that's not. That's okay. That's okay. And so that's about those kind of tests. Clock drawing is here. I don't have much to say other than it's either normal or not. Lab tests. Should we do lab tests? Yes, it's worth doing some basic lab tests. And these have always been recommended for a long time by many bodies, thyroid functions, in vitro levels, and so forth. I think the bottom line, though, is to do to do what makes sense. It's recommended in general that there be a picture of the brain taken, either a non-contrast CT or an MRI scan. Dr. Quinn mentioned the PET scanning. These are really only useful for, at this point, either for research purposes, except in a very special situation where you're thinking about a differential diagnosis of Alzheimer's disease from frontotemporal dementia, which I'll get to now. Actually, I have one more slide here. And then there are some other not rare tests, but other tests that might be useful. In cases where there's some question about the cognitive testing screening that you've done, so for example, if Einstein walks into the office, it's hard to really know how much a person's changed when they have already a very high level of functioning. So in that's an instance where doing more detailed testing by a neuropsychologist or psychometrist is very important and helpful. If there's a suspected infection, for example, then one may require or need a spinal tap. And then if there's suspected subclinical seizures, for example, an EEG might be helpful. But it's as indicated. And so for my last 9 minutes, I'm just going to talk about how these various features about the assessment and diagnosis are going to making specific diagnoses about the big 4 conditions. So this is all you need to know if you go to Las Vegas. If a person walks in your office and they're 85 years old, they have Alzheimer's disease. It's just statistically. Just want to bet on that, But we don't want to miss the things. And actually, they typically have more than one problem. But these are the way that things lay out. If you're a lumper, then most people have Alzheimer's disease. The second most common is probably vascular disease causing dementia. And then the other major disorders, frontotemporal dementia, diffuse Lewy body disease, and 700 other more rare conditions, which I guess is why I'm still able to sustain a referral practice. So Alzheimer's disease has a very typical, in its typical presentation, this insidious onset, slow progression, memory loss, particularly episodic short-term short-term memory, but also other domains are clearly affected, use of language and visual perceptive skills in particular. This affects function and typically unfolds over 8 to 10 years, but it's highly variable. So we've had patients who lasted a year with an autopsy, amazing case, but well out into 20 years as well. I'm going to say something about the stages because this is just something worth commenting on. The process or the progression progresses over several, is thought of as progressing over several domains. So cognition, we think a lot about cognition, but the functional aspects are more, drive really the practical considerations of what you need to do to help the person. And so initially, it's the higher order functions that are what brings a person in. So having difficulty with keeping track of medications or finances or using a phone or a computer. See a lot more of that these days. And then in the other domain that's important is there are behavioral changes. Typically early on, depression and apathy are very common. But then as time goes on, there are periods where these may wax and wane, you can come back again, but also the person may have periods of agitation, delusions, and more disruptive kinds of behaviors.
And unfortunately, I don't have time to really go over that in great detail. The pathology actually we talked about, and the imaging here is just shown to just emphasize that the progression. So this is the hippocampus where there's atrophy in the beginning, and it just continues, and that's just happening a mile. Well, it's typical of what one would see. In vascular dementia, the issue is really stroke. It's vascular disease. And because of that, it's driven by having some evidence of having had a stroke with a more abrupt, typically or classically abrupt period of deterioration. And it might fluctuate or have a stepwise course, which is believed to reflect having new small strokes. That classic picture, honestly, is not seen very commonly in pure form, but this is what we continue to teach. So I didn't want anybody to go away and give me a bad mark. But if you see it, it's very, very helpful. But this is a case where actually the imaging is really important, seeing vascular lesions on the brain. And what we typically see are either multiple large vessel infarcts, which is not as common as more strategic small infarcts. But typically we see multiple either deep or extensive subcortical white matter disease infarcts. And so these are just some images. This is a so-called strategic infarct. But this is the more common picture where one sees these multiple subcortical infarcts and periventricular white matter changes. I'm just going to briefly talk about the two dementias that are more uncommon, dementia with Lewy bodies. The classic syndrome here is dementia, which is not unlike Alzheimer's disease, although memory impairment may not be as prominent initially. But the key is that the person has Parkinsonism. Typically, they don't have a rest tremor, but they look Parkinsonian. They have some fluctuations in their cognition, but hard to get that history initially. They almost invariably, at some point, will have visual hallucinations. And these you have to ask about, because sometimes people won't talk about them or tell you. And they also may have, perhaps even related, more visual, spatial, or executive dysfunction in the beginning compared to memory. And if you get a history of a REM sleep behavior disorder, so these are people who will thrash about in their bed and knock their bed partner out of bed or themselves out of bed, that is also a very telling piece of history for making this diagnosis. These individuals, usually the dementia comes on with the Parkinsonism. They don't respond to levodopa as a typical person with idiopathic Parkinson's disease would. And underlying all this, though, is the same pathology. It's this alpha-synuclein inclusion in the neuron, or the so-called Lewy body, that causes it. Frontotemporal dementia is the other not common but rare, not uncommon, but certainly we see it occasionally, disorder. It's actually a collection of disorders that affects the frontal temporal regions of the brain. It has two forms, either a behavioral or language predominant set of symptoms. The behavioral dominant form is often will have a person who has problems or different changes in their personality with disinhibition, loss of social graces, and mental inflexibility. There is a surprising, at least initially, a lack of memory problems, so this really does differentiate those individuals. On the other hand, many, or a subset of patients in this spectrum of dementias will present with marked language problems, and initially may look like they have a progressive aphasia. Sometimes will be misdiagnosed initially as having a strange stroke that just keeps progressing because they have problems with their speech and language. And they typically have a younger age at onset, usually in the 50s or 60s, compared to a person with Alzheimer's. This is just some imaging. So these are focal degeneration. So this is the frontal lobe that's shrunken. You can see that here. So this is the normal there. And this is, it's a little bright here, but this is a focal atrophy of the left temporal lobe in a person with a progressive aphasia. I'm going to end by just reminding people that there's 700 other causes. This is one mnemonic that one can use to think about these. So there are many medical illnesses, medications, and structural things like tumors and so forth that can certainly cause a dementia syndrome, and those are part of the reason you want to investigate further when you suspect these things. And so I'm going to end. This is a summary of what I said. So we probably should have just started with this and been done with it. So we talked about the typical Alzheimer's syndrome, and then what differentiates this progressive memory and other cognitive domain decline over time is the concern about people who have more rapidly evolving or atypical presentations. Here, that temporal profile is extremely important, and lab tests and other ancillary tests are really important to think about in this domain. The key with vascular dementias is stroke, so think about that. Dementia with Lewy bodies is really a Parkinsonian syndrome with visual hallucinations, possibly sleep disorders, and these frontotemporal dementias either have dominant behavioral change or language change early on that progresses over time. With that, I did end on time.